Good afternoon, friends. I welcome you all to the second series of the webinar by Clinical Infectious Disease Society on COVID-19. And we had a very good response for our first series. And we're starting with ICU in the COVID, and the lecture will be by Dr. Babu Abraham, and who is a very highly rated critical care physician, and he's a pulmonologist. According to me, he's a cardiologist too, because he trained almost 3 years in cardiology and didn't take his exams. So he's a pulmonologist, cardiologist, plus a critical care person. And the moderator of the session will be Dr. N. Ramakrishnan. And Dr. N. Ramakrishnan is the head of the critical care services at Apollo Hospitals, Chennai. Apollo Hospitals, Chennai Critical Care Division is rated as one of the best critical care service in the country. And credit should go to him, the way he's been shepherding the unit for N number of years. According to me, he's a pioneer in the field of critical care medicine. And apart from critical care medicine, he is a great visionary. He has many roles to do. Let it be the sleep medicine or the tele-ICU. Right now, the government is behind tele-ICU, but he foresaw the impact of telemedicine many, many years ago. And he's a man who consults for people in US and other parts of the world too. And hope we have an enthralling session. And welcome you all again. And off to Dr. Ramakrishnan to start the session and moderate the session.
Thank you, Nambi, for the kind introduction. Good afternoon, all. I really enjoyed listening to the first series of the CIDS webinar, and it's a real honor and pleasure to chair the first of the second series that you have started. I'm very sure that Dr. Babu Abraham will throw light on the current ICU management. He has an ability to simplify very complex aspects of critical care. And in today's COVID situation, where we are uncertain about a lot of things, whether to do or not to do, I think we still have several questions unanswered, but he would address on what is the current understanding, current knowledge on the ICU management. The one request I have to the delegates is, I know there are different topics that are being covered, but if you can address your questions relevant to the ICU management today, that would be appropriate, which I would take on after he completes his talk. Over to you.
Thank you very much, Dr. Nambi and Dr. Ramakrishnan. As Dr. Ramakrishnan said, there's a lot of confusion going on with the treatment of COVID. And I would like to start by saying in ICU, we are not doing anything different from what we have been doing for all our patients all these years. All the new things are being done by people outside the ICU, by the infectious disease people, the immunologists, the virologists. They are the ones doing all new things. We intensivists are doing the same old thing. What I'm trying to do, we're going to talk today will be to try and take you through a patient who is admitted with COVID to the ICU and see how we manage them. Look at the guidelines. There are so many guidelines or position statements that have come out from various bodies. I've picked on two, ours and the one from the, when I say ours, the Indian Society of Critical Care Medicine, and the one from the Servine Sepsis Guidelines, and try to see how we are doing things. Are we going according to the guidelines, or are we seeing patients who are not fitting into the guidelines, and do we need to actually change things that we are doing? So let's go through the cases and see. My slide is not moving. Okay, so let's go through the case scenario. So here we have Mr. X, a 60-year-old man who has presented with history of fever of 3 days duration, body ache of 3 days duration, and headache of 3 days duration. Classical picture of any infection, isn't it? Any infection can cause that. But the important point here he gives is the history of having traveled for a business trip to China about 7 days ago. He also has a history of having been hypertensive and a diabetic. And on evaluating him, we see as a temperature of 102. He a pulse rate of 110, respiratory rate of 15 to 18, and he's saturating at room air at almost 98 to 100%. And he gets a chest X-ray done, and it looks pretty normal X-ray. However, because it's the COVID season, we go ahead and do a nasopharyngeal swab for RT-PCR, and that comes back positive. And he gets admitted to the isolation ward in a single room. Okay, and he's in the isolation ward being observed. On the third day of the admission, that's about 6 days into his fever, he starts showing some changes. But for him, it's only the myalgia. Otherwise, he's very comfortable. He continues to have fever now, but his heart rate has now slightly gone up to 120. His respiratory rate has slowly climbed up to 25, and his saturation room air has come down to 92%. But he is, normal. You ask him, I'm fine. I have no problem at all. And I think this is what people in the literature have started, describing as happy hypoxia or silent hypoxia, whatever you want. Now, what do? We get a CT scan done, and this is a CT. Now, if you notice, this is one of the classical features of the COVID CT, ground glass appearance, which are basically peripheral, and scattered. Okay, not very central. So when someone is hypoxic, what does the guideline say? They suggest that if anyone has a saturation less than 92, that he or she should be started on oxygen. Okay. They recommend that if it goes down to 90, definitely you have to start them on oxygen therapy. Okay, but maintain the saturation at around 92 to 96. So there is very clear evidence that we do not want to keep the saturation 100%. That's what we do it in ICU. The main problem being a saturation 100% does not tell us what the PaO2 is. Is the PaO2 500? Is it 300? Is it 100? So we do not want hyperoxia for any disease at all. So we want to keep it at a normal PaO2, which is anywhere between 90 to 100. So accepting a saturation of anywhere between 92 to 96 will help us achieve that. And if you see the patient here, he has a nasal prong, which is being used to give him the oxygen therapy. And because he is COVID positive, he has also got an NIV, so that when anyone walks, the healthcare workers who walk into the isolation room are not exposed to the droplets. So continuing with the case sheet, on day 5, he's with the oxygen. He becomes afebrile, but still has the myalgia. And you talk to him, he says, I'm very comfortable. Okay. But when you examine him, his heart rate has gone up further. Respiratory rate has gone up to 30. For a physician, when you look at him, you are not happy with the way he's breathing. And when you take off his nasal prongs, he desaturates rapidly to 82%. And that's when you become a bit more concerned and you repeat a chest X-ray. That's his chest X-ray. Compared to the chest X-ray, which is done about 5 days ago, you can see all the infiltrates in the periphery. So that is his chest X-ray definitely got worse. Even though he says he is okay, he feels comfortable, even though he's breathing 30 breaths per minute. Okay. So what do we do at this stage? We have to continue with the oxygen therapy. And now, because he is hypoxic, needing more oxygen, we go on to a device which will give him higher fractionation of inspired oxygen. And there are many devices. I've chosen a Venturi mask mainly because at least I can titrate the amount of oxygen I'm giving to him, and I will know clearly whether his lungs are getting worse. Because if I put him on any other normal oxygen devices, I will not be able to titrate the FiO2 the way I want. So he's on a Venturi mask, and I can titrate up the FiO2 to a maximum of 60%. Okay, so if his saturations or his respiratory distress does not settle with this, the next option I have would be to look at other oxygen delivery devices with like high flow nasal cannula, or even go one step further and give him a positive pressure ventilation and put him on a non-invasive ventilation with a positive pressure. So let's see what the guidelines tell us about the use of these two devices. Once we have exhausted the normal or ordinary oxygen delivery devices, when we are stepping up to the next level, what does the guidelines tell us? Okay, the high flow nasal cannula. So everyone in the ICU knows that this is a new kid when it comes to oxygen therapy. And if you look back at how many people have been using HFNC in this COVID era, from China, we see that about 1/3 to 2/3 of all critically ill patients who needed oxygen therapy had HFNC used. And there is very minimal data on HFNC in COVID. And the big worry, as with any device which has high flow, is whether we will aerolize, produce aerolization and aerolize the virus. So there are some guidelines which advise against using HFNC, whereas others say that no, there isn't aerolization of virus and you can use HFNC. If you look at the studies, there is one study which has looked at it, but it's an industry-sponsored study, which I would take with a pinch of salt. And they say that the particles that is produced with, from HFNC are larger particles, about larger than 10 microns in size. So they would be like any droplet. So if you keep your distance and use a 3-layered mask, should be okay, and you should not be worried about aerosolization. Having said that, it's a study from one of the companies that make HFNCs. Okay, so let's take it with a pinch of salt. What's the evidence for HFNC in outside COVID? Okay, there's a study which is clear. I've marked it, the study which clearly shows that it definitely reduces the need for intubation, and there is some evidence pointing towards maybe it could reduce mortality and reduce the length of stay, even though the evidence is not strong. With this background, we are going to see how we are going to use HFNC in patients with COVID. So as I said, the biggest concern is aerolization of the virus. Fine. So this is what the recommendation says. They suggest using HFNC over conventional therapy when the patient continues to be in hypoxic respiratory failure on conventional therapy, and they say they prefer HFNC over NIV. That's mainly because there is clear evidence from SARS and MERS epidemiological data that use of NIV, positive pressure through a mask, can cause aerolization of the virus. So that's why HFNC has been given preference over NIV. Okay, and when we use NIV, if we are worried about aerolization of the virus, we can use a 3-layered surgical mask or an NIV along with the HFNC so that the healthcare workers are protected. So this is one of the things that we do. Okay, so now if just with giving HFNC, increasing their FiO2, and we know that HFNC would give us a little bit of PEEP, CPAP, if the patient's hypoxic respiratory failure and respiratory distress is not settling, the next equipment that we have in the armamentarium for improving the oxygenation is the non-invasive ventilator. How do we do that? Now, NIV has been shown to decrease intubation mortality in patients with mild ARDS. However, when it is used in patients with moderate to severe ARDS, it could even create harm. So NIV can be given as a non-invasive small ventilator, which we call it bi-level or BiPAP, or through a large ICU ventilator. I'll show you both. Okay. Now, as I said, even though there are studies done in labs which show that aerolization from the NIV is mainly droplets, And it's not aerolization and small particles for aerolization where the size of the particles is less than 5 microns. Epidemiological data from SARS and MERS has clearly shown that healthcare workers have got infected when they've taken care of patients on NIV. Okay, so keep that at the back of your mind when you're using NIV. Now, sorry, how do I go back? Okay, never mind. So what are the recommendations? So the recommendations suggest that a trial of NIV can be given if there is no HFNC and there is no urgent need for an endotracheal intubation. And that too, it has to be done with close monitoring and short intervals of assessment. And what's the reason for this recommendation? Because very clearly, we have data that when it comes to hypoxic respiratory failure, NIV has been found to be useful only in a cardiogenic pulmonary edema. And all other cases, what NIV has been shown to do is maybe delay the intubation and lead to problems which even increases mortality by delayed intubation. So I think this is why that the recommendation very clearly says that it has to be only placed in a patient who has no indication for endotracheal intubation and has to be monitored very clearly. I think this is something that we have to keep in mind in the ICU, because a lot of times we give a lot of importance for intubated and ventilated patients, while a patient on NIV, we just slap a mask on, tie it around, push some buttons and walk away. And we do not give that one-to-one nursing, which is very important for such patients, to make sure and pick up, make sure that we are picking up any deterioration or lack of improvement, which happens when someone is on an IV. So the usual recommendation, not in COVID, but the usual recommendation is if you are placing someone on an IV who has a hypoxic respiratory failure, if they do not show any improvement, not even deterioration, if you do not show any improvement in the next 1 to 2 hours, that's when you have to reconsider whether you are going to stop doing an IV and move on to intubation. Keep that at the back of the mind. Now, here's a picture which shows using NIV through an ICU ventilator. Now, what's the difference between the two? Now, the ICU ventilator has a dual limb, so your expiratory air goes through the expiratory limb, goes through a filter before it comes into the atmosphere. So most probably the air which comes out of the patient is filtered, so maybe the viral particles would be much less. So it's safer for the healthcare workers. Now, even this, if you look at this picture, we can use a non-invasive ventilation mask onto which you can put a normal face mask. If you look at the picture carefully, this patient or the mannequin has a face mask placed on the NIV mask in such a way that even if there is any aerolization or a leak around the mask, the NIV mask, the face mask would prevent that virus particle from spilling over into the atmosphere as much as we can prevent. So that's one thing we can do. We can place an NIV mask and then cover it with a face mask, which will make sure that the aerolized air is at least partially prevented from getting into the atmosphere. Okay. Now, what are the recommendation is what sort of interface should you use? Now, studies from Italy showed that maybe using a helmet, a full helmet interface, worked better for preventing or decreasing aerolization, but I think there isn't enough evidence for that. But most of the guidelines say that you should use at least a full face mask, the mask which will cover the nose and the mouth. So it goes over the nasal bridge and comes down around the chin and mouth so that the whole face, or even bigger, goes over the forehead, eyes, and comes all the way down to cover your chin, nose, and the whole face. So you should not have the mouth exposed. You should not be using just a nasal mask. So the interface used should cover the whole face, which includes maybe even the forehead, the chin, nose, face, so the whole way. If you don't have that mask, at least make sure that the nose, the bridge of the mask sits on the bridge of the nose, covers the whole way around the angle of the mouth and the chin, so that the exhaled air goes back into the mask. And if it's a well-fitted mask, it should come out through the expiratory limb of the ventilator. Now, I do not know, I missed out one slide. I'm not able to go back. So I had a picture to show what are the additional precautions you should take when you are doing non-invasive ventilation through a BiPAP, a small machine. So few things that you should keep in mind is, remember that in a BiPAP machine, the exhaled air goes through a single limb. It has to come out through a port, an expiratory port, which will be in the single limb. So the exhaled air comes out without being filtered. So to prevent that, what is normally done is, do not use a vented interface when you're using a BiPAP, a small NIV machine. So use a non-vented mask and attach a filter onto the mask before you connect the tubing. We never used to do that before the COVID period because it increases dead space. Now we are going to add a filter onto the mask so that the air which is breathed out is filtered. Then it comes through and the air goes out through the expiratory port. And we do not use a heated humidifier when you are using the NIV. So these are the small changes that we should be doing when we are using a BiPAP or a small NIV machine and using that for a COVID positive patient. And even in this patient, the same thing, the mask can be covered with the face mask with the hole cut in the center so that you can put it through so that you can limit the aerolization. Okay, so the next. So let's see what happened to our patient. So he went on to NIV by day 7, within 24 hours of going on to HFNC. We tried NIV, and on intermittent HFNC and NIV, we take off the NIV, put him on HFNC for his meals. He looks very comfortable. But the thing that is worrying is the pulse rate and the respiratory rate and the way he desaturates rapidly. Okay, keep this in the back of the mind. Because this has got some implication when we are doing a positive pressure ventilation. That is also true with the NIV. When I'm talking about the ventilation, we'll come back to NIV to emphasize on this point. So he is breathing at 25 to 30 breaths per minute. That means he is generating a lot of negative pleural pressure to move air. Okay, keep that at the back of your mind. Okay, so because he has been going on like this for 3 to 4 days with no improvement, we decide to intubate him. Now, the question is there anything we can try before we intubate? Okay, so this is not a new kid on the block. Okay, this has been described as early as 2003, awake prone positioning. Okay, now this has been tried. It is not there in the guidelines, but there is news going around that centers have tried it. And there are small studies out there to say that awake prone positioning in non-COVID patients does improve oxygenation. And one of the studies from China has done this. And what have they found? Okay, it improves oxygenation. And maybe, sorry for the typo, it is maybe delay or prevent intubation. Okay. So it again, like a prone position ventilation in an intubated and ventilated patient, I think the mechanism is the same. It recruits more lung and improves oxygenation and gives us and the body time to recover. Okay, I think this is something worth trying, even though it's not there in the guidelines. It is really a harmless, or a procedure with very little harm, and it's worth trying. Okay, so who can be prone? Okay, so please don't prone people who are ready to get intubated. Okay, that might be risky. So prone someone whose hypoxia is not getting corrected by even going up to HFNC. Then if the patient is hemodynamically stable and is able to move around in the bed and position himself without help and able to communicate, that's the patient maybe you should try. There are certain contraindications. As I said, if they are in respiratory distress and about to fail, about to get intubated, please don't try on them. They should be hemodynamically stable, should be awake enough to communicate and be appropriate, and should not have any of this unstable spine, thoracic injury, and all those things. Okay, so there is a guideline for how to prone patients and how we do it. Okay, so what we're going to do is we are going to ask the patient to lie flat in the prone position, and what we do is observe for 15 minutes. If the patient is not desaturating, hemodynamically stable, and in fact, if he's improving, we allow him to lie flat for at least 2 hours. After 2 hours, he then is asked or requested to move position and come to a left lateral position, again for 2 hours. Then he is made to sit up at 30 to 60 degrees for another 2 hours. Then he is made to lie on the left lateral for 2 hours, and then you go back to prone position again for 2 hours. So the patient has to be willing to do this. You have to talk to the patient, convince him to do it, and keep changing this. So this is the protocol which has come out of UK. Okay, and they have also given a good algorithmic approach to it. And this is how your patient will look. You're going to keep 3 pillows, one under the chest, one under the hip, and one under the shin, so that your chest, your abdomen, the abdomen falls free, and the patient is able to breathe properly. And if you look at him, the next picture, yeah, he has a HFNC and an N95 mask on, and this is how we prone the patient. Okay. Now, our patient was not put on awake prone position. He was intubated directly. So we have decided to intubate him. Okay. So he is continues to be tachycardic, tachymic, and we have taken the decision to intubate and ventilate. Now, intubation is one of the procedures that will produce a lot of aerosols, and we have to be very careful to do it. Even though this is, I'm not going to be able to tell you everything about how to intubate, but there are certain things that we need to take care of. And only the most skilled operator should do it. And that should be in full PPE, okay? And limit as many people as possible, only the 2 or 3 people maximum. You should pre-oxygenate a patient for a good duration of time, get the oxygenation up to the best you can, and do a rapid sequence induction. If you have a video laryngoscope in this picture here, if you see this doctor is intubating, look at where he's looking. He's looking at the screen of the video laryngoscope. That helps in not having to stoop down to the level to have a look directly in to see the larynx. Otherwise, we have to come very low down to the level of the face. And even if you have done a rapid sequence, there could be a small chance of aerolization. So with the video laryngoscope, you can stand up and be far away from the face. Okay. And once the patient is intubated, you confirm the position with EtCO2. And once he's intubated, you always use a closed suction system so that aerolization is good. Now, there is very strong evidence from the SARS epidemic that healthcare workers can get infected. In fact, in Toronto, the healthcare workers that we have lost without all died or contracted the disease after having intubated patients. Now, this is the algorithm that we are finding the guidelines, which tells you how to go about to take care of a hypoxic patient. Now, once you have intubated, the next thing is you need to ventilate. Now, what do the guidelines tell us about ventilation? Okay, so the guidelines are
excuse me, doctor, your voice is very low.
Okay.
Your earphone is unplugged.
Am I better now?
Yes.
Okay, I'll hold. So the guidelines tell us to, okay, the guidelines tell us to ventilate the patient using a lung protective strategy. All of us know what the lung protective strategy is, and that's exactly what they have said. They said 4 to 8 ml per kilo, and keep the platelet pressure at less than 30, and use a high PEEP. That is the strategy which has been suggested. Okay. Now, what we have seen is every patient is different. What I would like to highlight here is this, okay? This is a COVID patient as he comes to you. Now, the lung protective strategy has been described well for ARDS. Yes, you can call it ARDS, but this is not how an ARDS lung looks, the typical ARDS. The COVID lung has got a lot of normal lung, aerated lung, and it's very compliant. So when we are using a strategy of using 4 to 8 ml, using a PEEP greater than 10, keeping a platelet less than 30, and we are doing it for a lung which is fully compliant, you need to be very careful, especially when you're increasing the PEEP greater than 10. Because it's a compliant lung, it will accept the PEEP very easily, but then it gets transmitted across, and hemodynamic hemodynamic problems can set in. Now, what you need to understand is these patients, if you have read the Gattinoni paper, these patients, as I said, are breathing at 30 to 35 breaths per minute, and they are generating huge negative intrapleural pressure. So when you put them on a positive pressure, the transpulmonary pressure is very large. And when a large transpulmonary pressure of greater than 15 to 20 can cause more lung damage. So instead of just jacking up your PEEP, you have to see whether by increasing the PEEP, are you creating more of these problems, in creating more of the higher transpulmonary pressure, and you have to have a better way of monitoring what the PEEP does. So this is where Gattinoni brought in the terminology of PCILI, that is patient-induced or patient-induced spontaneously in lung injury. Okay, so be very careful. Otherwise, even when you're doing an NIV and giving positive pressure, that can create a large negative interpleural pressure and cause more harm. And that can further lead into a classical ARDS-like picture. So when a patient with COVID goes on to develop this picture, which is a classical ARDS picture, after a few days, we are not sure whether it's because of the disease getting worse or whether it is our poor ventilatory management which has caused the stress-induced lung injury to. So once they reach the stage, then they behave like the classical ARDS patient where they have a low compliance. So these group, the first group, initially they are called the phenotype L. When you say L, it's a low elastance, which means the elastance is low, which means the compliance is good. The second, they progress into a phenotype H, that is high elastance, which is a very low compliance, and that is the classical ARDS. Now, I think we should keep this at the back of the mind, because in our enthusiasm to improve the oxygenation, we jack up the PEEP, and by jacking up the PEEP and creating the CILI and making it worse, will really push the patient into a worse lung condition. And to prevent that, we should titrate PEEP using some other method of monitoring PEEP other than just looking at the platelet pressure. Because the compliance is very good, the platelet pressure may not go up that much. So you should look some like things like the driving pressure, or if you have the the facility to do place an esophageal balloon, maybe even monitor the transpulmonary pressure. So that is what you need to do when you're ventilating these patients. And another thing I've seen is once you ventilate the patient, they are hypoxic. You have to leave them on maybe 100% of oxygen for some time. Anyway, sometime about at least 6 to 8 hours. And very slowly, the need for FiO2 will start settling. Within about 24 to 36 hours, the patients that I have seen, usually we are able to come down on the FiO2 to about 50%. You need to give them the time. I think we just have to be patient and allow the lungs to heal. Remember that what we are doing in ICU is supporting the patient. In our enthusiasm to cure him, I request that we should not be doing harm. And with time, the FiO2 requirements will come down. Be careful when you increase the PEEP initially when our COVID patients have near normal compliant lung. Okay, now what do we do about sedation and paralysis? Very important. As I said, the recommendation is this, okay? When there is moderate to severe ARDS, give a bolus of paralytic agent. And when there is a lot of dyssynchrony, use continuous infusion. Many of the patients that we have heard about, most of them have this high flow requirement. So there will be dysynchronous because you will not be able to provide that sort of flow on a ventilator, and you will end up giving them high sedation. Despite sedation, they will still trigger the ventilator, you will end up paralyzing them. I think it will be a good idea to sedate and paralyze them for at least 24 to 48 hours to allow the lungs to heal and then slowly come off the paralytic agent and see whether just on sedation, we are able to ventilate them without any dysynchrony. Okay, now, what else can we do? We have intubated, sedated, paralyzed the patient, and we have given time. We have waited for 6 to 8 hours to 12 hours, and we are still not able to come down on the FiO2, still on 100% FiO2. What can we do? We do everything that we normally used to do for our normal ARDS patient. Prone position ventilation can be tried. They say no to NO, and it's a strong recommendation. I do not know why. Looking up at it, they say that no mortality benefit and an increased incidence of renal failure. But I use NO to buy me time. As I said, at the end of 12 hours, patient is still not, we are not able to come down on NO2, and proning needs about 7 healthcare workers in the room to turn the patient out. In my normal ARDS patients, we don't even think twice. We flip them prone. Even in the middle of the night, most of my doctors do it. But when it comes to COVID, you think twice. Do you want 7 of the healthcare workers to be exposed to this gentleman? Or can I try something else? So yeah, nitric oxide, if you have access to it, try it. You give it for maybe 24 hours and might buy you time to bring down the FiO2. Yes, the guidelines, the surveying sepsis guidelines recommends inhaled pulmonary vasodilators over nitric oxide. We don't have access to it. And they also suggest that maybe we should try recruitment maneuver. My suggestion would be, unless you are very comfortable with doing recruitment maneuver, please do not try it on a lung which is very compliant. We may end up doing more harm and barotrauma by doing it. Yes, in the later stage, once they go into the phenotype H, then maybe you can do it, but initially be very careful. Fine. Still patient not getting over? Yes. Everyone wants this ECMO. What's the evidence? Not very much evident. But talking to my friends in UK and in the Middle East, they are resorting to ECMO. Yes, if you have the manpower, you have the setup where you can do ECMO, you can think about doing ECMO for patients who are not responding. Hypoxia is not getting corrected with all the procedures that I talked about before. Okay, because it's very resource intensive and it's expensive. And especially if you have large number of patients who are sick, I do not know how many of them we can be doing ECMO. If it's just 1 or 2 patients, maybe yes. But yes, if you have access to it and you have experience in doing it, ECMO is also there. Okay. Now, quickly, should we do anything different for the hemodynamic resuscitation? Really, no. Here, they suggest that when we use fluid resuscitation, should be more conservative. But I do not know, maybe the audience would have had more experience than I have. But what I have seen is, initially when patients come to us with fever and we intubate them, they drop their blood pressure. And when you assess the volume status, they are preload responsive. And by fluid resuscitation, we will be able to get them off the vasopressors. So yes, we should be cautious. We shouldn't be overzealous and flood our patients, but I think we should not be too conservative and hold back fluid. We should give enough fluid so that we optimize the preload. Okay, no role for albumin. This is all what we practice. Use norepinephrine, noradrenaline first, follow it up with vasopressin, okay, and your mapped target is 66. So nothing different from what we normally do in the ICU. Fine. Now, impossible to tell you what we do, everything that we do. Once we decide, once the patient has improved and we decide to extubate, how are we going to do it? Okay, remember that extubation is also aerosol generating. So all the precautions we took for intubation has to be taken over here too. So first, stop all the sedation, see whether the patient wakes up appropriately, assess whether he's stable for extubation. Okay, keep everything ready by the bedside itself for helping his respiration or his or her respiration after you extubate. Make sure that you are fully protected with PPEs. Do a thorough oral suctioning before you extubate. And before you extubate, a lot of authorities recommend using an antitussive like lidocaine to prevent cough. And then, this is not in the protocol, but I saw this come up from a British Journal of Anesthesia just recently. They use a mask over tube technique, which I found very useful. You need 2 health workers at the head end. Now, sorry, I can't go back. Do you know how to go back? Nope. Can you get me to the other? Yeah, the picture, the previous one. Thank you very much. Thank you very much. So, only thing I would have done different is I would have used a polythene sheet, which we normally use for intubation. Look at what they are doing. 2 people at the head end. Sorry, can I go back to the previous one, please? Previous one, please. Can you help me with that? Yes, thank you. Leave it at that. So look at what they're doing. They have got a mask, okay, an anesthesia mask ready with a viral filter. Patient is fully awake. You are going to give this patient antitussive. You're going to prop up the head to about 30 degrees. You're going to suction the oral cavity. And then you're going to place the mask just around the face, there. And the tube is brought to the side of the mouth where the healthcare worker who's going to extubate is going to be, okay? Then just before the cuff is deflated, the healthcare worker is holding the mask, pushes down the mask with both hands, and cuff is inflated and the tube is withdrawn. The mask is held in place with the oxygen delivery device. And if the patient coughs, he coughs into the mask, and the exhaled air goes out through the filter. Seems to be a good method. I think it's worth trying it. And if the patient is extubated, this is the last slide. This is an algorithm that has been put up in the surveying success guidelines as to how you will approach a patient with mild, moderate, or severe ARDS. Thank you.
Thank you, Babu. That was a good, very comprehensive overview of what we do in the ICU and very appropriately illustrated with a case. We do have several questions, and I just want you to take some of them, what we can in the next 10 minutes or so. There was a question even before you started your lecture, and that was about steroid use. So there was a question on what is the preferred steroid, what is the dosage, and what is the duration in critically ill COVID patient. Please.
Okay. Good question. The answer is I don't know. Okay. Why are we giving steroids is the first question. I think the rationale for giving steroids is to bring down the inflammation. And during the inflammatory phase of the infection, I think steroid will work, bring down the inflammation, and we have seen that the patients improve. The oxygenation improves, the patient's requirement for oxygen dramatically settles. But my institution, my experience, my group's experience with H1N1, the swine flu period, was that if they are intubated and ventilated and you put them on steroid, they remain on the ventilator longer and develop secondary infection. And we have lost a lot of patients to secondary infection after steroids. So I am very hesitant to use steroids unless there is some evidence which tells that it will work. Even if I'm going to use, not going to use it in intubated and ventilated patient. Am I going to use it in patients before they get intubated? I don't know. I need to be convinced. At this point of time, there is no strong evidence. And as I said, see, this is an infection. If our body has the immunity to fight it, we will come out of it. We need to support the body. Let's not do harm by thinking that by giving all these things, we are going to make the inflammation go away fast. Okay, that's the answer I have.
I completely agree with you. I mean, I can't think of any recent illness where we've not considered steroids. And then, we either give it and that can get confused. As of now, I think there is no evidence convincing us to routinely use it. We may say something different in the future if there are formal studies looking at it. Okay, the next question is, sir, I understood that the recommendation is to use surgical mask for the patient and N95 for the healthcare worker. So I'm a bit confused why you have mentioned N95 for the patient, because it can be suffocating, and why not a 3-ply mask?
Yeah, you're true. You're correct. N95 is N95 is usually kept for the healthcare workers, especially when they are entering into the room where you're doing some procedure which is going to cause a lot of aerosolization. And for the patient, unless he's coughing violently, I don't think he will be aerosolizing that much. So a 3-layered mask should be enough. Yes.
Dr. Nambi, do you have a comment on that?
No, I agree with that. I think a 3-ply mask, a surgical mask for the patient should be more than enough. In N95 mask, let us restrict to the healthcare workers alone.
Sure. There is a related question, Babu, where somebody has asked, can you really put an N95 mask over a venturi?
Over a venturi? No, I don't think you can put an N95 mask over a venturi. You may be able to put the cloth mask. N95 mask will be difficult.
Yeah. There's a question on what about negative pressure and HEPA filter in ICU in preventing, he says spillover, but I'm sure he means aerosolization.
Correct. So yes, what do we need? We need to create a flow of air from the room to the outside. Oh.
We want to see you, Babu. Your video is off.
Yeah, I don't know why the...
That's okay. We can still hear you while you fix that. Yeah, you're back.
Yeah, I'm coming back. Okay. So I think, yeah, okay. So, yes, if you have a fully made negative room, which gives you a negative pressure, fantastic. Otherwise, what can you do? You need to have the air flow from the room to the outside. So yes, you can put exhaust fan good enough to get enough air out, and have a HEPA filter so that this air is filtered and goes out. So it's a makeshift negative pressure room. It's a poor man's negative pressure room. Let's put it that way.
There's a question which you've answered in some parts earlier, but the question is what precautions are needed while putting the patient on NIV and hypolonic camera?
Okay, so NIV, as I said, precautions that the healthcare worker should take, or the precaution
Both.
they have not mentioned?
No,
Both.
they have not mentioned, but please go ahead with it.
Okay, so as I said, the concern is with NIV is high aerolization. So if you are entering a room where there is aerolization, you have to have a full PPE put in. That is a full suit which covers your head, your leg, your hand, have gloves, have goggles, shield. No part of your body should be exposed when you enter. So NIV, there is evidence that it's epidemiological evidence, okay, that it can aerosolize the virus. So Nambi, don't laugh at me. Okay, so the healthcare worker should be wearing something. From the patient point of view, we want to make sure that whatever comes out of him has the least amount of virus in it. So that's why if you're using a single limb BiPAP onto the mask, you're fitting a viral filter. You're going to use a mask which is not vented so that all the air, if it's a tight fitting mask, comes through the filter, comes out and goes out to the expiratory port. The other thing I said is you can use a cloth mask around the interface to try and cut down the amount of air which is coming out into the atmosphere. Those are the precautions we can use.
One other quick thing I want to add to what you said is when you place the NIV mask and turn the machine on, put the mask first, turn it on. Similarly, when taking off, turn off the machine and then remove the mask. That way you are minimizing the cough effort and the possibility of—
Very true.
Sir, is there a CPAP? Does CPAP cause complication in patients with COVID and other illnesses? I don't know what exactly they mean, but the question is does CPAP cause complications in patients with COVID?
So the only thing I think, I do not know whether the question was to do with the Gattinoni paper. So CPAP per se does not have added a complication which is not found in other diseases. Whatever sort of complications you see in other diseases is there for COVID too. The only thing is any positive pressure ventilation in COVID patients who are tachypneic and generating huge flows creates a huge negative creating a huge negative intrapleural pressure, and a positive pressure at the other end causes a very large transpulmonary pressure. And the large transpulmonary pressure can cause the stress-induced lung injury, which can later on lead to a full-blown ARDS. So when we are using positive pressure, we have to be careful. Maybe try and make sure that you give him some sedative, something to cut down his flow requirement. That, I think that is the question what they are asking. Yeah. Not sure.
Can you comment on permissive hypoxia, which some intensivists are talking nowadays in these COVID patients?
So, okay. Now, fantastic concept. For whoever who asked, I do not know whether they knew that when someone climbs Mount Everest, okay, and at the top of Mount Everest, if you do an ABG, 3 people have done it. You go back and look at the literature. The PaO2 at that level is 30 to 35 millimeters of mercury. So if you have given your body time to acclimatize, permissive hypoxia works. But unfortunately, COVID doesn't give you the time. Okay, COVID, your saturations drop quickly. So in a healthy young individual, maybe a low 80 would be okay. 82, 83 should be okay. Maybe if you can't ventilate them, we accept 82 young people. Elderly people with coronary artery disease, all that, if you keep them at low 80, they will develop complications. So permissive hypercapnia, you have to choose your patients carefully and see who you can titrate accept a lower saturation. But I don't think clinically anyone can say that, oh, you can accept a saturation less than 85. I mean, I will be comfortable with 85 in a young, healthy gentleman who has no other comorbidities, very stiff lung that I cannot ventilate. I might accept an 85% and sit tight. So not more than that.
Okay. There are several questions, but we have only about 2 or 3 more minutes. So I'm just going to pick a few of them, and if your answers could be brief. Is there a role for the HAT cocktail, the thiamine ascorbic acid?
No evidence. No evidence, so I can't comment on it.
What is the survival rate once patient goes on invasive ventilation?
Okay, very good question, because I don't have enough experience. If you look at the Western literature, the mortality is about 75 to 80%. Okay, but I don't know how to interpret it. This is what is coming out of UK, Italy, and all that. For us, the numbers that we have ventilated too small that we cannot even comment on it.
So there is a theme. There are 3-4 different questions. The theme is that, is there a difference in the ventilator strategy between other influenza and the COVID that you're seeing? And,
okay, that theme, the phenotype L, with a good compliance, okay, low elastance, good compliance, was seen in H1N1. In fact, when we went for international conferences, we used to tell the Europeans, the swine flu patients I see are, hypoxic with good compliance. And they used to look at us and say, is that so? So where is the evidence? We never collected our data. Okay, now they see it and they become the masters. So I think it's an inflammatory process that we see with most of the viruses. We have seen it with H1N1. We are seeing it with Corona. So I don't know whether it's going to be there for all viruses, but definitely it's there for H1N1. It's definitely there for Corona.
Last question, any role for nebulization, any role for hyperbaric oxygen?
Okay, now whoever asked me the question, I would like to know why they want to nebulize. Because I do not know. It's like, everyone gets a nebulizer, but for what? Now, remember that nebulization is also aerosol generating. So please do not use a small volume nebulizer in your NIV patient or HFNC patient. Use only MDI with a spacer device if you have to use it. If you're using it on a ventilator, go for a vibrating mesh. There also it reduces practically very little aerosolization. So yes, if you need to use a nebulizer, use a spacer device MDI or a vibrating mesh.
Okay. There have been several questions regarding, interferons, anti-inflammatory drugs and stuff, which I would just summarize and say that they're all right now on a research experimental mode. None of them are proven. And so we need to wait for the real answers. Thank you, Babu, once again for patiently answering those questions, and over to Dr. Senthurnam.
Thank you, Dr. Babu Abraham, for a lucid lecture, and thanks, Dr. Ramakrishnan, for moderating this session. I think there have been a lot of questions on therapy. I think to put it simple, no one knows if any of these antivirals or anti-inflammatory agents are going to be of any benefit. Probably we need to have more experience and exposure with the use of these drugs. Right now, I think the key take-home message would be to do no harm, support the organ in whatever possible way. I think that should be the mantra until for the next 2 weeks, 3 weeks, till we get more information. Today we got information that the so-called remdesivir, which looked very promising, now the trial data say that it's not going to help much. So things are changing. HCQ was put at the top, and now all of us know where hydroxychloroquine lives and with respect to COVID. So the key message is support the organ, do no harm, and then minimal interventions and minimize the healthcare contact with these kind of sick patients, do what is necessary. And thanks once again, Dr. Babu and Dr. Ramakrishnan. And I thank the delegates for coming in for the webinar. And the webinar is accessible through Zoom. And people who have come in late or who have missed it, You can always watch the lectures in YouTube. All you have to type is CIDS webinars. And again, from tomorrow, we will have this lecture posted in the CIDS website, the CIDSindia.org, which also has an exclusive section on COVID with guidelines, updates, all those stuff. And this will be tomorrow's session, and that's going to be case-based learning. And it's going to be a panel discussion where we're going to have 3 ID guys, and you're going to have a person from CMC Vellore, Rajiv Karthik, presenting real-life case scenarios to get real-world inputs from people from other parts of the country, starting from Kerala, Mumbai, and Pune, who have managed such patients. Please do join for another enthralling session tomorrow at 3 o'clock. And thanks, viewers, for joining in. And thanks, Dr. Ramakrishnan and Dr. Babu Abraham, for sparing your time and showing your little experience, valuable one for us. Thank you.
Thank you.